Welcome back to this session presented by Miss Amito Prudence. As we had started looking at newborn physiological adaptations following birth, so today we shall be continuing with the adaptations that takes place following birth. So previously we looked at respiratory system and we looked at cardiovascular system. So today we shall be looking at hematophytic system, phytic system. So when we look at this hematophytic system, basically we are looking at the hemoglobins. So while in uterus, the newborns have this or this hemoglobin for the fetus, or what we call fetal hemoglobin, has higher affinity for oxygen. But at birth, newborns have high affinity for the newborn hemoglobin have strong oxygen affinity, but reduces tissue delivery. So one of the things that takes place is, as this is happening, there is going to be what we call physiological anemia, which occurs by 3 months following pregnancy. So in most cases, that's why you find that when a woman is pregnant, they are prone to become anemic, because because we know that the hemoglobin has iron inside. So when the fetal hemoglobin is having stronger affinity or high affinity or attraction to oxygen, so you find that most of the iron is being attracted to the fetus, and then the mother is left with just less. So this causes what we call physiological anemia, most times by 3rd month of pregnancy. So the iron stores are derived from maternal transfusion in the uterus. So what happens at birth is for us to delay cord clamping about 30 to 60 seconds. In most cases, we feel like it's too long to wait for the cord. Even we are supposed to wait up to 3 minutes before you clamp and cut the cord. So the reason as to why you should delay cord clamping is to increase blood volume by about 80 mils per minute. We also want to enhance iron and oxygen delivery. Remember, when the fetus was in the uterus, it had a stronger affinity for oxygen. So this made other tissues to have reduction in iron. There was that less iron being received by other tissues. So the reason why we delay cord clamping is to make sure that there is that transitional exchange or enhancement of oxygen and iron during delivery. So the next is coagulation. So we have vitamin K dependent factors like factor number 2, number 7, number 9, and number 10, which are low due to the sterile guts. Remember, while in the uterus, the fetus was not able to feed, though we see that in most cases, there is amniotic fluid that pass through the guts of the fetus, but the gut is still sterile at that time. So the fetus has that low dependent factors for coagulation. That's why we do give vitamin K injection at birth. So vitamin K injection is essential to prevent bleeding disorders. So if these surfactants are not produced, so you find that the fetus might have poor coagulation. So our next is gastrointestinal, hepatic, and immune adaptations. So these adaptations, the first adaptation that takes place is feeding. So we just finished seeing that the fetus has a sterile gut. That means it has not been eating. But we saw that I mentioned that there is amniotic fluid that usually bypasses through the guts. So the GIT must adapt to allow for digestion and absorption of nutrients from breast milk or other formulas. So as the fetus is being born, the GIT should adapt to allow digestion and also absorption of nutrients. As earlier on, it was not doing that while the fetus was in the uterus. Then we have hepatic adaptation, that is bilirubin conjugation. So the liver begins to conjugate bilirubin, which is a waste product of red blood cell breakdown. So this conjugation of bilirubin, it allows the waste products of red blood cells to be broken down, and hence it prevents the fetus from having what we call jaundice. So if the liver does not conjugate these bilirubin, that means the fetus might, after few hours or days, present with what we call jaundice or this yellowish skin. Then the next one is immune adaptation, which is immune system. So the immune system adapts, develops and provides protection against infection outside the uterus. So that is one thing the fetus should adapt to immediately at birth, to make sure that any kind of infection outside the uterus, they are protected. So our next adaptation is thermoregulation. So when you think of thermoregulation, basically we are looking at temperature regulation. So we do, the fetus or the newborn do adapt to temperature regulation, one, by maintaining body temperature, or how we help them to adapt, maintaining body temperature. So the newborn must maintain a stable body temperature due to loss of placental heat transfer and their underdeveloped thermoregulatory mechanism. So at birth, they really don't have a fully developed thermoregulatory mechanism. Remember, while they were in the uterus, it is the placenta that used to maintain the heat transfer. So we need to make sure we maintain stable body temperature due to loss of placental heat transfer. At that time, the placenta and the fetus have already been separated. Then we have non-shivering thermogenesis. So this is where the newborn relies on non-shivering thermogenesis, the production of heat through metabolism of brown fats to maintain core temperature. So the fetus also adapts by its own by making sure it produces it through metabolizing brown fats, which it had, to make sure they receive some core temperature. Then another way of adapting to temperature is by preventing heat loss. So there are strategies to prevent heat loss in most cases. When the fetus is just born, or when the newborn is just born, we adapt to, or we practice what we call drying the newborn and wrapping them, placing them in a warm environment are very essential. So this will prevent the newborn from losing heat. So that is how we do thermoregulation adaptation. So we have some newborn challenges. One, less subcutaneous fat. So you find that there are some newborns or some babies who are born when they are having less subcutaneous fat, especially those born prematurely. So that is a challenge because Babies with less subcutaneous fat tend to lose heat faster than those with fair subcutaneous fat. Then we have high body surface area to mass ratio. Those with high body surface area to mass ratio tend also to lose temperature or to lose heat more than those other ones with less body surface area. Then we have blood vessels close to the skin. There's some fetuses who have blood vessels, actually almost all of them. You find that you are able to see the blood vessels just under the skin. So that alone can easily predispose them to heat loss. So we have some other heat loss mechanisms like convection. So they can lose heat also by hair currents. That means just hair passing through their skin can easily make them to lose heat. They can lose heat through radiation. If you put a cooler object nearby to them, they can easily lose heat. We have evaporation. So as the fetus is born, most times the body is wet with the amniotic fluid and all those things. So that's why we normally practice drying the baby thoroughly. It's very, very important. If you do not dry the baby thoroughly, there is evaporation. So the moisture on the skin or the amniotic fluid on the skin will make the baby to easily lose heat, and they might go into hypothermia. Then they can lose heat also by conduction, that is contact with cool surface. So in most cases, we prepare our bed sheets and blanket to receive the baby. So make sure you don't put the baby on a cool surface. Then we have this non-shivering thermogenesis, where we talked of metabolizing brown fats. Then there is also increase in oxygen use and glycogen depletion. Then we have what is called cold stress risk. So the cold stress risk is mostly makes the fetus to go to hypoglycemia when they lose too much heat or temperature. They can easily become hypoglycemic. They can easily become hypoxic. They can easily go into acidosis. So let's be very, very important with providing heat to the newborn. So premature infants are at even a greater risk due to limited brown fats. So those ones who are born prematurely, they have less brown fats. So they cannot metabolize completely the brown fats to make sure they are having the non-shivering thermogenesis. So let's make sure we give the babies, the newborns or the babies, we cover them with 3 sheets: the blanket, the heavier sheet, and then the light sheet. So thank you so much for listening, as we have looked at the most important adaptations that are very key for newborns functioning while in their first hours extrauterine. So we looked at respiratory system, we looked at cardiovascular, we looked at GIT, hepatic, we looked at immune system, we also looked at thermoregulation, we looked at hematophytic system. So all these systems are very, very important for us to monitor, especially to allow the fetus to thrive or survive extrauterine. So thank you so much for listening to this session. I urge you to do more research, find out on other things that we might have left out while looking at newborn adaptations. So our next session shall start next time. Thank you for listening.